I'm Dr. Matthew Pollard, and we're going to talk about direct lateral fusion. Direct lateral fusion is a surgical technique where we fuse the bones in the lumbar spine together. There's a variety of indications or reasons that might need to be done. One of the most common is back pain or a bone slipping out of position. Another common occurrence is narrowing in the spinal canal. If there's enough narrowing in the spinal canal, by fusing the bones together with this technique, we can take the pressure off of the nerves also. Occasionally we'll do it for infection or other indications, but those are the main reasons we would consider doing it. There's multiple ways to fuse the bones together in the spine. The direct lateral fusion is one of the newest ways, which is one of the safest and less morbid or easiest to recover from. In other words, there's a lot less scar tissue and a lot quicker recovery with less pain involved. In that technique, we make an incision on the side, directly on the side of the body, and instead of coming through the back or the front, we come down through the side. This is a model of a spine. The front of the spine is here, the back of the spine is here, and here is the side. In this technique, we would come down through the abdominal wall, through the psoas muscle, which sits on the side of the spine, and then go down into the disc space itself. Once we're in the disc space, we remove the disc and place a disc replacement in that looks about like this. It fits very nicely into that space. That will stop the motion at that level if motion is the problem, and by inserting a disc that's taller than the normal disc, the native disc that was in there, we indirectly can decompress the spinal canal. And for many patients, that results in tremendous relief of their symptoms. Occasionally, for a variety of reasons, we'll put a plate on there in addition to the disc replacement. Occasionally, we'll flip the patient over and through very small incisions, put some traditional pedicle screws in the back. Anytime you have surgery, there's always risks. Risk of infection, chance of damage to blood vessels and nerves, need for more surgery. All those are very unlikely with this technique. We do find a quicker recovery for most patients. Most patients do have some weakness in hip flexion initially due to the approach through the psoas muscle, which helps to flex the hip. Almost always that's temporary. On rare occasion, in 1 out of 20 patients at the L4-5 level, there can be a nerve injury. Usually that's temporary. At the higher levels, the odds of that are much, much smaller. The recovery for this is pretty quick. It's usually a 1 to 2 night stay in the hospital, resuming normal activities as tolerated or once you feel ready. Usually people are back to work, depending on how strenuous the job is, anywhere from 1 to 2 months on average.